Good evening, everyone. Welcome to this webinar. I am Uma Venkatesa, Head of Pelvic Floor Physiotherapy Department from Jogo Health Private Limited. This is a company, Jogo Health is a digital therapeutic device company. It's a US-based company having Indian operations. We use a digital therapeutic device in different forms of rehab sector. Pelvic floor rehab, stroke rehab, orthopedic, neurology, pediatric. So we have got several areas. Today, we are going to discuss about reducing incontinence in RARP, Robotic Assisted Radical Prostatectomy. We have a special person here, Dr. Ananthkrishnan Sivaraman. He has started his own hospital recently. It's called CuriHospital, that is Chennai Urology and Robotic Institute. He is a consultant urologist, Oncologist, and also a robotic surgeon. He has done specialization in minimally invasive robotic surgery. He is conducting fellowship program for robotics. He was a manager editor for the Journal of Robotic Surgery from 2010 to 2012. He has authored several chapters of different books in robotic surgery and robotic training. He is also in the faculty in University College London on a robotic center for the advanced robotic course as well as robotic surgery. He has done several camps nationally, internationally to create an awareness about prostate issue and prostate cancer. So he is also the founder of Indian Prostate Cancer Foundation. So it's an honor to have you, sir. We welcome you for this lecture on incontinence, reducing incontinence in RARP. So it's all yours, sir.
Thank you, Ms. Uma. So first and foremost, I must thank all of you for giving us this opportunity to speak about our experience in robotic prostates. So without further ado, I'll just share my screen and then we'll try and start with the talk, right?
Yes, sir.
Right. Okay. So the topic today is improving outcomes in prostatectomy, and we're focusing on continence, right? So what we have to understand straight away is that continence is not something that's something that stands alone, right? Continence is something that it's tied up with other parts of the prostatectomy. For instance, there's no continence if you don't talk about cancer control, or if you don't talk about sexual function as well. So these functional outcomes, oncological outcomes are all tied together. You can't have one without the other, right? So the important questions are, what are the keys when you're talking about improving outcomes? What are the keys to reducing positive margins? And how does this play with continence, right? Improving early continence and improving early potency, right? Because they're all related, you see. So have we been able to achieve acceptable outcomes, and what are the key principles in achieving the trifecta? When I talk about trifecta, I'm talking about oncological outcomes as well as the functional outcomes, especially continence and potency, right? And what are the keys to improve our results persistently, right? So we've crossed more than 1,000 prostates, and these are some of our perioperative outcomes, but we won't talk about that right now. What I'm going to talk about is what sort of experience we have in terms of reducing complication, because this is also something that's important, especially bladder neck contracture. This plays into our talk, especially the continence part of it. And bladder neck contractures, I personally haven't seen in the last more than 800 cases or something like that. So this is something that's gone out of one of the complication lists because because of the advances in technology, the way we are able to see the mucosa and so on, right? But what's persisted is hemorrhage. Sometimes it really doesn't. The best case of the day can potentially give you a bleed, and these are some things that has still persisted, right? Very rarely anastomotic leak or retention and embolisms, the DVT leading to embolisms. These are some things that you always have to be looking out for, right? So, I'm sorry, right? So, the lessons learned in achieving the trifecta, especially cancer control, continence, and sexual function. First is when you talk about the trifecta, the experience of the surgeon matters, right? I've always, it's most of the papers or published articles currently talk about the surgeon experience as one of the key factors. Tumor status of the patient, that's very important as well. You can't expect to do a T4 tumor and then achieve perfect outcomes for the patient, right? So we are as good as what we operate on. So exceptionally bad tumor, exceptionally, it's a locally advanced entity. And these are things that will automatically reduce your outcomes, right? Comorbidities of the patients, it's a very weak, as soon as a patient walks into your clinic, we'll be able to tell whether that gentleman's going to have a good outcome or not. The way he walks, how fast he walks, and so on. These are things that I always look out for in my patients. And the digital rectal examination is key. What am I assessing in the digital rectal examination? The prostate, definitely. But I'm also assessing the tone of the musculature, the pelvic floor musculature. And I think this is a very key component when you're assessing a patient for prostatectomy. If you've got a very poor tone, right, and his muscle tone is pretty bad, these are patients that don't do well post-surgery. And key points to this surgery are the apical dissection as well as the neurovascular bundle preservation. Now, a lot of people say that neurovascular bundle preservation plays more into potency results, but I also think it does have a definite influence on the continence outcomes as well, right? So the first, we're talking about cancer control, and this is first and foremost, this is a oncological surgery, right? Within reasonable limits, if you're able to ensure oncological safety, then you would concentrate on the continence and sexual function. It is definitely something that's related, and I would say inversely related. So you really, for oncological control, you need to go wider. But for, as you'll see from this talk, but for the functional outcomes, you need to be closer to the prostate, right? The best sexual function results are obtained when you do a complete nerve preservation, for which you need to be right on top of the capsule, right? We know that when the cancer goes out of the prostate, it goes into the neurovascular bundle. So if you say you're going to preserve 100% of the nerves in a patient who's got extra prostatic extension, you make yourself liable to have positive margins, right? So it is a cancer operation, that's number one. And once we ensure oncological safety, we look at the other two parts of the outcomes, right? So what are the factors that are predictive? As predictive, like I said, we're as good as what we operate. It's clinical stage, pathological stage, and percentage of tumor burden, right? Big prostates, locally advanced, you are going to have poor oncological outcomes, and clinical stage is lower, not a great tumor burden, and you will have good outcomes for these patients, right? So how does it tie in with our talk today, right? Especially the continence part of it, right? For continence, one of the key components is the urethral length. How much of the urethral length you're able to maximize is key, right? So when you're talking about cancer, if you have an apical tumor, a lot of tumor burden here that affects, then your ability to preserve the urethral length may be compromised, right? So when you do an apical dissection, is preservation of tissue anatomy versus oncology and vision. So if you look at the prostate here and the three components in the apex of the prostate, so you have the DVC anteriorly, you have the urethra in between, and then you have the posterior urethral plate, right? So the urethra is actually covered by, you've seen these elderly gentlemen with cervical problems where a cervical collar, there's something like that covering the urethra. So you need to get rid of the DVC, and then you need to get rid of the cervical collar, but not to make the urethra very thin. And then you need to separately tackle the posterior urethral plate, and I'll tell you the reason why. Because sometimes the apical tissue of the prostate, especially the posterior lip of the prostate, travels much, much above compared to where the anterior lip of the prostate is. So, for instance, you have the prostates that, this kind of prostate is very good to have. It will not lead to a large posterior positive margin. But this one here, this particular prostate, you see that this has got a large posterior lip, and you're liable to cut through the posterior lip if you don't, if you're not cognizant of this aspect, right? So if you look at this, to maximize the urethral length, you need to cut as close to the prostate as possible. And if a patient has got a large volume tumor at the apex, this is where you will tend to get more positive margins. We know that every millimeter that you save on the urethra has a potential to influence your continence, right? So this is what I mean. So if it's a large volume tumor on the apical zones, you can't be skiving close to the prostate. You will end up either touching the posterior lip or getting into the apex. You will need to go slightly wider, whereby you lose this length of the urethra. And if you lose that length of the urethra, then the continence outcomes are going to be poor. Like I said, it really depends on what sort of prostates we operate as well, right? So this is an example, a video that I wanted to show you. So this is how we do. So you see, we've already done a DVC stitch and a suspension stitch. I'm going to be talking to you about this, but we're looking at a step in the prostate surgery that's towards the end of it. This is towards the end of the prostate. But I wanted to show this first to emphasize that oncology ties in with continence as well, right? So here we're tied the DVC, and then we're cutting through the dorsal vein complex here. So this part of it, and the urethra has been periurethral tissues next to the urethra, they've been suspended up as well. So there you see. So this is the part that I was mentioning about the urethra wearing a collar, right? So you've crossed the dorsal vein complex and you're on top of the urethra. So this aspect of the prostate, you need to be very careful. You should never make the urethra too thin so that it's only hanging by the mucosa. That's not a good those patients will have not great continence outcomes. The urethra should have a sufficient thickness as well. So here I'm trying to get between the urethra and the posterior urethral plate so that you tackle that separately, right? Only for identifying those cases where there's a posterior lip in the prostate, right? So I wouldn't dig too much down here between the prostate and the urethra if a patient has got anterior tumor. And all this brings to the point that you need to have good preoperative imaging, know exactly where the prostate tumor is, do a proper mapping biopsies of the prostate so that you know preoperatively where the tumor is, and then you'll be able to cut exactly where you want to, right? So that's key here. So tumor burden and the location of the tumor determines how much of the urethra you can save. And we know that each millimeter that you save on the urethra really helps with your continence, of course, right? So here we're cutting through at this particular point, and I'll show you where are the potential areas that you could cut through the urethra as well. So you see that the veru here, so we're right on kind of the right place where we need to cut the urethra. So this is what I was alluding to. So you can, depending upon the tumor burden, either cut here, here, or here. And that's how oncology, the oncological status of the patient or the tumor and the location of the tumor affects the urethral length, which in turn affects the continence as well, right? So again, what are the factors? The increasing experience, this allows you to maximize urethral length. And preoperative mapping, like I said, you need to have a proper 3 Tesla MRI. I need to know where the tumor is and a mapping biopsy of the prostate. And as nerve preservation, I'll come to that a bit later as well. And this helps with continence outcomes. The next, actually, we're talking about continence outcomes. And this is what, incontinence is an issue, right? After prostatectomy, though we've come a long way now, nobody, or I must say very few, very small percentage of the patients who undergo prostatectomy have incontinence at the end of 1 year. They may have one safety diaper. Some people are stuck in their minds having safety diapers, so they're always a bit afraid that they would wear safety diapers. But if you see towards the end of 1 year, predominantly incontinence as an issue settles down. But our goal as prostate surgeons is to give the patients earlier continence. Can they become continent much earlier? 1 year is too long a time for, so they should be continent as soon as they take the catheter out, or within a month, 2 months, 3 months. What can we do as surgeons to improve this continence issue, right? So regarding incontinence, despite all of the technical innovations, it's very hard to predict which patient will develop incontinence, right? So you might have a perfect patient, athlete, who's got a good, muscle tone, but they may not be continent, right? And I've also found that people who have difficulty, you've heard of dyslexia, isn't it? Learning difficulties, right? Some people also have learning difficulty in terms of the Kegel exercises. For the life of them, they won't be able to do the exact Kegel exercises that they're supposed to, right? So that's where some of the physio that you're going to hear at the end of this talk comes into play, right? Teaching the patients exactly how to do this physiotherapy really plays into their ability to regain their continence earlier, right? So who are these outliers? Can we really predict them? I'm having difficulty predicting who's going to have incontinence long term, and what can we do to improve the chances. So there are a set of mechanisms, methods that we follow, and I hope this is something that we can all gain from. So right, there's already been, most of it has been published, and the first thing is the bladder neck reconstruction. We do a fish mouth reconstruction. The second one is an anterior suspension stitch, where we suspend the periurethral tissue to the retropubis. I'll be showing videos of all. And the third one is the Rocco stitch, or the modified Rocco stitch that we do, right? So, and the reason this is important is there are two key areas, right? The anterior part of it and the posterior part of the urethra, both of which need support. And once we, reconstruct the prostatic bed in such a way, then the potential to regain continence earlier is much higher, right? So we're going to talk about, so this is one situation where we've done a racketing, and this is because the urethral orifices were very close to the prostate. Usually it's not our plan, but saving the urethral orifices, trying to not get them on the anastomosis is one key point here as well that needs to be kept in mind, right? So the periurethral suspension stitch, this is key, right? What is the advantage of a periurethral suspension stitch is it anchors the urethra, right? Doesn't allow the urethra to move too much, and it anchors it more up to the near the pubis, right? So this is how it's done. I'm going to show you a video as well. So this is how we do a periurethral suspension stitch. The first stitch is usually a dorsal vein stitch. So there's a lot of controversy regarding whether you need to tie the DVC before you cut it, or whether you can cut the DVC and then tie it, right? So I belong to the school of thought that says tie the DVC and then cut it, right? It falls in with the Halsterian principles of surgery, where before you cut something that bleeds, it's better to tie it, isn't it? So it also helps with the vision, and it allows you to see better, so that you're not able to, you won't injure areas of the prostate because of the bleeding or something like that. So I always tie the DVC and only then cut it. I've tried the cutting and then stitching, where it bleeds quite a bit sometimes, and it's really not a good feeling to have blood all over the field, right? In that one step, you can lose about 100 ml of blood or something like that. That's not a good feeling. So I always tie this. Now, this is the point that I think helps with the continence. So here, I've done the DVC, but by doing the DVC, you go into the notch of the prostate. Here, you go slightly behind the notch of the prostate. So you're in the periurethral tissue, but not in the urethra per se, right? And then you anchor it to the retropubis. Right? This is how we anchor it to the retropubis. The idea of anchoring it to the retropubis is anchor the periurethral tissues to a fixed structure so that it doesn't not too mobile. Right? So that's one of the key components. And I think it's been published as well. I trained with Dr. Patel, and whilst I was there, this was published saying that it does help in early continence. But like I said, open prostatectomy, lab prostates, and robotic prostate, a lot of them, the continence becomes okay at the end of a year. The goal of us uro-oncologists is mostly to get the continence done earlier rather than later. And all this ties in with that, right? Small steps that have incremental value and give the patient that comfort where they're continent much earlier. Right? So with suspension, without suspension, at the end, so some difference in early continence in the patients who had suspension stitches, right? And then we'll talk about posterior reconstruction as well, right? So we've spoken about anterior reconstruction, suspension stitch. Now we're talking about posterior reconstruction, and here it's modified version. So the original stitch was Rocco stitch, an Italian professor of urology, and that's been modified over subsequent years. And actually, this paper was published whilst I was working in the US with Dr. Patel. So the goal here is to connect the denovilus to the posterior urethral plate, and then also connect the posterior bladder neck on the second step to the posterior urethra. So the advantages are twofold. First step gives you a hammock behind the prostate or behind the urethrovesical anastomosis. And the second step is a kind of a reinforcement layer for the posterior urethra. So what happens is the posterior urethra, the chances of leakage at the posterior urethral level are very, very minimal. And I also think it reduces the tension when we're doing the anastomosis. And not only that, the first step of the Rocco's reconstruction reduces or increases hemostasis as well. So hemostasis, reducing tension, and buttressing the posterior urethral wall are some of the goals of this reconstruction. And it's been proven that it definitely helps with earlier continence, right? So, so this is what I'm talking about. So there's anterior reconstruction at this level, posterior reconstruction at this level. And so you're securing the urethrovesical anastomosis. Not only that, what you're doing is giving it a proper bed to lie down on, right? So again, so this is a video of showing this anastomosis. So the first part of this video is fish mouth closure of the bladder. So this is what we do in fish mouth closure of the bladder. Is always mucosa to mucosa, single thickness, that is full thickness bites. The next step is the posterior reconstruction, right? So here you see that we are joining the denovilus to the posterior urethral plate out here. So we're taking the denovilus here and then joining it to the posterior urethral plate out here, right? Just below the urethra. And this area, once you bring it up, acts like a hammock. So the urethrovesical anastomosis is able to lie on the hammock so that it has a bed to lie down. So again, it's not under tension because you brought the periurethral tissues as well as the perivesical tissues back together. And the final step, or the second step of the Rocco's, so Rocco's got two steps. First one was urethral plate and denovilus. Second one is posterior urethral wall to the posterior bladder wall, the bladder neck, right? So the advantage of this is, again, like I said, buttressing. So it gives support to the posterior urethral part of the anastomosis, posterior part of the anastomosis. So chances of leaks are much higher. And before you start the anastomosis, both the bladder and the urethra are together, right? So again, reduces tension, makes the anastomosis far, far easier. And once you do this, right, the anastomosis becomes a piece of cake. You can do the entire anastomosis in 5 to 6 minutes. It's all done. So again, so anterior as well as posterior reconstruction are key to preserving continence in a patient's having radical prostatectomy, right? So the next is, let me quickly skip this video. So you see urethra and the prostate and the bladder are together before we even start the anastomosis, right? So again, these are conventional ways of doing this. Now there's recently Reducing sparing surgery has come, and the continence results are encouraging, but really we need to see whether oncological safety is being compromised when we do a Reducing sparing surgery. And that's one of the reasons I don't cater to the idea that bladder neck preservation is good as well. So because a lot of times you may have tumor that's very close to the base of the bladder, and these are patients that don't do well when you do bladder neck preservation. So again, that's important. If possible, if the tumor is purely apical tumor, you can potentially preserve the bladder neck. But if you're not sure, or you don't know where the tumor is, or it doesn't look good, I wouldn't go with bladder neck preservation. My policy is I would, the internal sphincter is always compromised when I do a prostatectomy, right? And mainly the key component is the external sphincter. So Reducing sparing and bladder neck preservation, again, if possible, yes, but I would suggest these be done for tumors that are very low risk tumors, not high risk tumors, where you risk the chance of getting positive margins, right? Finally, sexual function. Now, how does sexual function play into continence, right? When you're doing nerve preservation or partial nerve preservation, I think over and above the sexual function, it helps with your continence outcomes as well, right? So that's something that we have to look at, right? So again, how do we do nerve preservation? Athermal, atraumatic nerve preservation, very, very important. Pneumoperitoneum definitely helps. And surgical judgment, that's key, right? Not all nerve bundles are meant to be spared. And the reason why we talk like that is, if you're you can't promise a patient that I'll do bilateral nerve preservation and go into the operating room and see that it's completely stuck, right? So counsel the patients always based on their preoperative MRI findings, based on their pathological findings, biopsy findings, and their preoperative sexual function, right? So the patient needs to be sexually active in order for us to give them the benefit of nerve preservation, right? So that's key to, so when to and when not to preserve nerve preservation, that's key, right? Oncological surgery, if there's a lot of tumor on the lateral aspect, don't go ahead and preserve nerves and then have positive margins, right? So in that case, you can tailor the surgery for each particular patient. All you need is a proper ability to read MRIs and a properly done biopsy that tells you where the tumor is. And if you have a lot of tumor on one side of the prostate, try and do a non-nerve sparing that side. And there's no tumor on the other side, try and do a nerve preservation. Or you have two tumors on both sides of the prostate, consider partial nerve preservation. There's a lot of study being done on this. And based on the prostatic artery, whether you go medial to the artery, lateral to the artery, how much of the nerves you are able to preserve and so on. So I think that's key. Not all nerve bundles need to be preserved. And when you do a nerve preservation, I also think it helps with your continence, right? So, and this, I think this is one of Walsh's original diagrams. And sorry, let me get back to this, right? So this is where the nerve bundle is, just posterolateral aspect of the prostate. And this is the money step of the prostatectomy, right? You need to be able to preserve the nerves without getting into the cancer cells, right? So again, that's where you get a nerve preservation or a non-nerve preservation increment. So this is the neurovascular bundle that's on the prostate when you do a nerve preservation. This can be quantified, right? How much of the nerves is being preserved or saved and so on, right? That's important to understand as well. So here you're seeing an eye where we're releasing the early retrograde release of nerves seen here. This is the technique that we follow, lateral aspect of the prostate, right? Cut one of the lateral fascial layers of the prostate, right? I never do an intrafascial nerve preservation. Most of it is, here you see the prostatic artery, the artery that I'm talking about. If you're medial to this prostatic artery, you will preserve most of the nerves. If you're lateral to the prostatic artery, you tend to lose some nerves, but that plays into your ability to leave some tissue on the prostate to prevent margins when you're thinking about extra prostatic extension, right? So here, it's very difficult to make a mistake. You see this plane between the prostate and the neurovascular bundle. That's the key step here, right? Once you create the plane, you can push the nerve bundles away, and then the patient will have good continence outcomes as well as potency outcomes, right? So here, you see this artery here, you're able to see this artery, my pointer pointing here. So that artery needs to be preserved, right? Once you preserve that artery, you can go along the contour of the prostate and preserve the rest of the neurovascular bundle as well. So this is how we do a nerve preservation. And again, I don't have to remind you over and over again. My policy is always that it's an oncological. So you see this artery here, that you see some pulsations out here. That's the artery that needs to be preserved. You need to be medial to the artery when you do a full nerve preservation. You can be lateral to the artery when you're doing a partial nerve preservation or an incremental nerve preservation, right? Let's quickly go to the next slide. Again, potency outcomes, trifecta outcomes, potency, sexual function, continence, and cancer outcomes. So these are things that we as uro-oncologists are always looking at. And tied into that, we also started looking at pentafecta outcomes, which is complications and margin rates as well, right? So this is something that we've been looking at over a period of time. So the best surrogate for oncological outcomes currently that we have is margin rates. That's also something that needs to be given. We need to be cognizant of that, right? So I'll quickly skip a few slides. And yeah, this is the point that I was talking to you about, the prostatic artery, right? You saw the prostatic artery in the picture, the previous picture. So this prostatic artery can be identified and it runs along the lateral aspect of the prostate, and you just need to stick medially to give a good nerve sparing outcome, right? So before I finish, all of our patients that undergo, we've crossed more than 1,000 robotic prostates, all of our patients are counseled preoperatively about the potential side effects, right? You have to counsel the patients on what are the options available, including active surveillance, robotic prostatectomy or prostatectomy, and radiation, including the types of radiation, and hormonal manipulation as well. That's very, very important. You do not want a patient coming back to you and saying, I did not know that there's a potential radiation available. Why did I have surgery, right? Because all of these interventions for the prostate have some sort of side effects, right? The side effects have to be explained to the patient. And foremost out of it, especially in our country, now after the age of 60, not a lot of us patients in our country are clamoring for the sexual function. But continence is something that a lot of people come and ask us, right? So I always teach them preoperative physiotherapy, and we need to make them learn what muscles they need to use. And that's key, right? Because I always felt that even sometimes very intelligent people, professors, are not able to grasp this concept of Kegel's exercises. And that's where biofeedback comes into play, right? When you give them biofeedback, when you teach them which muscles they're using appropriately and are they using it appropriately, I think the continence outcomes improve significantly. And that's something Ms. Uma will talk to you about. Before I conclude, this is what I wanted to say. Prostatectomy is built on principles of open surgery. We all learned from open surgery. I've come away completely from open, especially in prostatectomy. The last time I did an open prostate is more than 10 years ago. And in experience stands, you will have good outcomes in prostatectomy, and effective pelvic floor physiotherapy is quite useful for patients, especially in terms of continence. Thank you very much. Hope you've all learned from this, or thank you for this opportunity, right?
Thank you so much, Dr. Ananthkrishnan.
I just stop my share. Did I?
Sure.
Yeah, right. Yes. Happy to answer any questions if you may have.
Yes.
Are we getting?
And, we will do that. And thank you so much for a wonderful presentation. And you explained clearly about how important we need to give 3 key factors like cancer control, urinary incontinence, and then sexual function. And also, you explained clearly about the specific techniques, surgical techniques to have the bladder neck preservation, and then specific surgical technique to preserve the bladder neck and all the details. I'm sure the audience will be able to understand, and they are going to ask questions. In the meantime, I'm going to do just a quick presentation. We are waiting for the questions from the audience. Can you stop sharing, Doctor?
I think I've already stopped my share, man.
Okay. One minute. I think some issue from my end, I think.
What picture are you seeing now? Yeah, I can see you. Yes.
Okay. So, okay, sure. I'll have a quick presentation of my talk. Can you see my screen?
Yes.
Sorry. So I'm going to talk about post-RARP incontinence JOGO therapy, that is EMG biofeedback therapy. So JOGO therapy can be used in male pelvic floor conditions, incontinence in post-RARP, chronic pelvic pain, male sexual dysfunction, and pediatric incontinence. So they've done, originally they were doing a lot of studies. Whatever that is was applied for women suffering from incontinence, they were applying the same principle in men also. Then Hodges did a pioneering work that there is a different anatomy and biomechanics and muscle physiologies, and we can't apply the same principles in men. So he came up with a large study and established a new path in the pelvic floor rehabilitation. We just wanted to share a case study where a 74-year-old male who is a known case of a post-RARP with urinary incontinence came to Jogo Health on 12th of January 2022 this year, with complaints of leakage of urine while coughing, sneezing, from sit to stand and stand to sit, weightlifting, turning in the bed, walking and laughing, and in all physical activities with increased urgency and frequency during the day and night time. He was completely dependent on the diaper. It was soaking wet, unable to void in the toilet. Surgery details, like he underwent RARP on 16/12/2021. On the day of evaluation, we follow SOAP format, subjective, objective, assessment, and planning. In subjective scores, we ask the patient different questions like Quotient score and ICIQ International Questionnaire on Incontinence, 3IQ, 3 questions on incontinence, and then IIQ, that is impact of incontinence on the quality of life. And then we take the scores. Then we do the urogenital assessment and we assess the power of the muscles. Perfect score we do where the power is 1/5, endurance was 1 second, repetitions was 3 repetitions, and forced contractions, quick contractions was 3 times. He was using all the accessories muscles except the pelvic floor muscles. He was using abdominal muscles, gluteal muscles, inner thigh muscles, and anal muscles. As a pelvic floor physiotherapist, we can observe and assess those muscles. The cough test was positive. He was leaking 20 to 25 ml. And we also did a JOGO biofeedback assessment by keeping the surface electrode in the urogenital muscles. So the slow contractions, the patient had difficulty to do urogenital contractions. and he was able to do ischio-cavernous contractions for 1 second only. And then his microvolts second calibration was 11 to 12 microvolts second, and he was able to hold for only 1 second. The quick contractions, he was able to do 3 quick contractions of IC with usage of more abdominal and muscles and gluteal and inner thigh muscles. It was 11 to 14 microvolts seconds for only 3 repetitions. We also did the perirectal examination where the perfect score was power was 2/5, endurance was 2 seconds, repetitions was 3 reps, and forced contraction 3 times. The bladder behavior, the bladder diary was also given, and urine output can't able to void it in the toilet. The leakage was 1700 ml, change of diaper 4 diapers, daytime frequency every 2 hours, nighttime frequency 5 times, and stop test he was unable to do. So with a structured pelvic floor physiotherapy using Jogo therapy, he was given once a week for 10 weeks. So at the end of the 10th sessions on 26th March 2022, his Cosian score remained the same. IC-IQ improved from 20/21 to 8/21, 3 IQ S2A 3A to S2A 3A mild, IAQ from 14/21 to 3/21. So urogenital assessment power from 1, it has improved to 2, endurance from 1 seconds to 4 seconds, repetition 3 reps to 5 reps, and forced contractions from 3 times to 6 times. And he was doing isolated pelvic floor contractions, not using the accessory muscles. Cough test was negative. Jogo biofeedback assessment using surface electrodes for urogenital, it has improved. The patient is able to contract the pelvic floor muscles, IC and PB, with minimal usage of anal and abdominal muscles, able to maintain the contractions for 4 seconds, and also improved 14 to 16 microvolts second. And quick contractions also is able to do for 5 quick contractions, 14 to 18 microvolts second. Our rectal examinals also, the power improved from 2/5 to 3/5, endurance 2 seconds to 4 seconds, and repetitions 3 reps to 5 reps, and forced contractions, quick contractions from 3 times to 7 times. The bladder behavior, 300 ml per day, leakage was only 50 ml, change of diaper nil, and daytime frequency was voiding every 4 hours, and nighttime frequency 3 times, and stop test 2 minutes. He was able to stop the midstream for 2 minutes. So the patient was very happy. He got rid of the diaper. So he was able to function normally. As you can see on the first session, this is the blue is the ischio-cavernous contractions, and red is the perineal body. And then you can see at the end of the 10 sessions how he was able to control his muscles better and also improve the strength. Quick contractions where type 2 fibers are very essential for stress urinary incontinence. If they are not strong, the patient will leak. So predominantly this patient was having stress urinary incontinence. As you can see, the first he was not able to do properly. In the 10th session, you can see the 1, 2, 3, 4, 5 quick contractions, and also the improvement in the microvolts seconds. So after 10 sessions of intensive pelvic floor muscle strengthening program using Jogo, bladder retraining, bladder diary, home exercise program, now patient feels no leakage in coughing, sneezing, laughing, sit to stand, no urgency and frequency, is able to void urine in the toilet with minimal leakage in walking, and sometimes in getting up after prolonged sitting. So no usage of diaper now. Overall, patient says 80% improvement, and physiotherapist felt 85% improvement. So how Jogo works? It works on the principles of operant conditioning, where the technique is learning based on the learning theories, where you use time and again, with reinforcements and feedback, audio feedback, and this visual feedback. So you're able to learn better. So in this, the electromyographic responses of weak pelvic floor muscles are seen in the form of bar graph or the waveform or in the ball. So we put the surface electrodes on the pelvic floor muscles. The afferent impulses are carried down through the S2, S3, S4 route through the spinal cord and reaches the brain. Brain registers and then learn the normal contractions, and the efferent impulses are transmitted, thereby relearning the neuromuscular mechanisms through the long loop mechanism and increasing the urethral closure pressure, which is very important in incontinence. So this is the JOGO equipment device we use, where you can see the surface electrodes, we have the probes, we have the sensor, GX sensors, which is connected to the tablet through wireless mechanism, and we can see the graph. And this is the small video I want to show you the different parts of the JOGO digital therapeutic device with adhesive electrodes, GX sensors, the probes, and the tablet, which is connected through the wireless app-oriented program. This lady is doing wrist extension. As she is doing, you can see the bar graph going up, and she can understand the muscle behavior by looking at the graph, and we can set the goal step by step on a daily basis. This is a pelvic floor patient where the blue is the pelvic floor muscles and red is the transverse abdominis. So we wanted to focus on pelvic floor muscles. So the blue graph is going up and red should not go up. So she can learn through the visual feedback and then isolate the patient. He can learn the isolated pelvic floor contractions. Thank you so much, and we are waiting for the questions. And doctor is here to answer all the questions. You can post the questions in the chat box so that I can ask the doctor one by one.
So a couple of things that I wanted to talk as well. But,
Sure.
a lot of our patients have used JOGO, and one of the key points that I've felt over the last 1 year is that a lot of the patients are quite happy when you teach them exactly which muscle they need to be using, right? So, and the results are quite encouraging. So I think it's, I become a convert, and previously I used to teach them Kegel's exercises myself, and then I'd keep a finger in the back passage and then ask them to contract, and then see if they're contracting well, the force of the contraction was it good or something like that. And then I've also done it with the ultrasound, transrectal ultrasound, to show them which are they contracting the muscle well and so on, right? But a lot of patients have difficulty in identifying or understanding exactly which muscle. So the key advantage, I think, is your visual graph that you're able to show the patients, right? So
Yes.
they're able to see how much of a contraction, and because it's in real time, the contraction that they do is directly proportional to the height of the graph that they see on the screen, right? So I think it's that's one of the key elements of the biofeedback that we're teaching patients right now, right? So that's an important component that I wanted to talk about. And the other point is, Uma, you and your team, very good at explaining the issue. So most of the patients that we see, they do better if the condition is clearly explained to them, right? For instance, even when we talk about prostatectomy, the counseling sessions take place for at least an hour. They need to know what exactly is their situation, whether they come under the low risk category, intermediate risk category, or high risk category, and what is the proposed treatment. What are the chances of having incontinence after surgery? What are the chances of having sexual dysfunction? And what are the chances of requiring further treatment as well? Say, for instance, if they've had surgery, what are the chances of them having multimodal treatment at a future date? all of this needs to be explained to the patient before you take him to the operating room. And that's something that I've seen in your team. They're thorough in explaining the condition to the patient, as well as giving us responses about how the feedbacks about how the patients are doing over a period of time. So again, all in all, I am pretty convinced that for post-prostatectomy, to get patients to an earlier level of continence, I think this biofeedback physiotherapy is essential. Like all of the components need some sort of rehabilitation and physio except for instance, penile rehabilitation, right? That's also a key component of allowing the patients to achieve the trifecta as soon as possible. So
yes. Thank you so much, sir, for explaining. We are still waiting for the questions from the audience, and either you have clearly explained so well, there is no doubts for them. So you have done a great job in explaining in minute detail. We are still waiting for some of the questions from the audience. So let's wait for a few minutes. If there are no questions, I know you are very busy. You have got other things to take care of. We'll wait for 5 minutes, sir, for the questions.
Okay. That's okay. Right. So, how many centers does Jogo have?
Yes, we have standalone clinics in Madurai, Coimbatore, Trivandrum, and also we have 2 centers in Malaysia and a couple of centers in US and Canada. And in Chennai also we have several clinics where our therapists go and give JOGO therapy and rehabilitation to all those patients. So we work from 8 a.m. to 9 p.m. We are also working on Sundays. So we are here to serve all those patients who need our help. So we are committed. And as you said, education is the key. The patient, each and every patient, we spend quite amount of time in educating them about the pelvic floor muscles and using the pelvic floor model and educational materials. And also we train the staff with all this advanced training so that they are confident in teaching these patients and treating these patients on a week basis, and then make sure that they understand the home program and perform it efficiently.
So pelvic floor musculature is key. Do you want to talk about the scissoring effect of the pubococcygeus versus the puborectalis?
Yes. So most of the doctors and therapists will do the assessment per rectum. But what happens after the prostate surgery, the level of the bladder next comes down. So it is giving a negative effect. So that is the reason we focus more on urogenital component, urogenital muscles, transverse perineum, ischio-cavernous, and then focus on that, not making the anorectal as a dominant factor. You can't avoid that, but at the same time, we can't make it as a dominant factor to prevent the scissoring effect and aggravating the incontinence problem. Okay, so somebody has asked questions, can you comment on post-TURP incontinence?
Right, so post-TURP incontinence is also a real problem, though we don't see it as much. Here, there's a direct damage to the sphincter that happens. It can either happen because of the cautery that's being done, or you resect part of the sphincter when you're doing a transurethral resection, right? So it is a real problem. Of course, physiotherapy and bladder relaxants will be the first line of defense against post-TURP incontinence. But these are usually entities that are not that are a bit recalcitrant to conservative treatment, and more often than not, they may end up having an artificial sphincter or something like that. So I think, for instance, when you talk about robotic prostatectomy over a period of time, it has a chance to improve. But when a TURP, when you damage the sphincter significantly in a TURP, the chances of recovery are a bit less. But having said that, the incontinence after TURP is very, very rare nowadays, right?
So what is the outcomes of the, once they get continent, or your patients, do they approach for ED problem also?
Yes, yes. So both these entities are tied in together. When you talk about cancer on day one, when the patient comes to you and so on, the first thing that most of our patients, especially here in southern India, say, "Doctor, I'm really not worried about anything. I just want to live," right? So once the cancer is well under control, or that the prostatectomy is done, and the patients always, a lot of them come back and say, "Listen, I'm now cancer free, but I don't feel complete if I'm not able to have proper sexual function." So that then the penile rehabilitation. So I always ask the patients this, right? Number one is, are they preoperatively potent? And there's something called a shim score that needs to be calculated before we take them for the surgery. And if they really are potent, we go all out to try and preserve the nerves, provided oncologically it is safe, right? If we are able to do a good nerve preservation, then the chances of returning or getting potent is very high. If we do a partial nerve preservation, again, the chances of coming back are higher, but they may need further penile rehabilitation. And if we do a complete non-nerve preservation, it may not have potent. It may not be potent without additional help. Additional help meaning a vacuum pump, or the PDE5 inhibitors, or the penile injection therapy, which is either Cavaject, Bimix, Trimix, and that's available here in India. We can give them a good outcome. Sexual function after radical prostatectomy, people can be given good outcomes at present.
Thank you, doctor. And how about people who are smoking and drinking? They couldn't stop because of the addiction. Because of that, do you think that incontinence may not stop because of the other reasons?
Smoking is definitely a risk factor. Not only for the continence level sexual function, but also as a risk in surgery. People are high-grade smokers, especially when you're doing robotic surgery and putting the patient in a Trendelenburg position. Trendelenburg position, it kind of, the lungs don't do that well if you're taking high-grade smokers. I would ask patients to stop at least a month before they undergo surgery. I think smoking is a key entity that we need to be, very, very sure that patients stop it before they have surgery. Alcohol, again, it makes the tissues not great. There's a little bit more bleeding when a patient is an alcoholic. And I've also seen withdrawal symptoms immediate post-operatively, and that's difficult to manage as well. So again, chronic alcoholics who have this problem, I would be very wary of taking them on.
One question in the chat box, I think it's for me. Sir, ED is common after RARP. How to avoid that? Does physiotherapy will help for ED? Certainly, there are so many studies have been taken. Even we have treated quite a few people. So certainly we can try and help these people for that problem.
ED after RARP is proportional to the amount of nerves that have been preserved. Right? If you preserved a good complement of nerves, and if you preserved a good amount of nerves, and athermally it's been done, I think the chances of getting ED potency back again is pretty high. Right? But all of the patients will need some sort of penile rehabilitation. That's mandatory. Okay?
Sure. Thank you so much, doctor, for taking your time and explaining in detail about the RARP, in and out about the surgical techniques and rehabilitation. Thank you so much. Have a great evening. Thank you all for logging in. And I thank Jogo admin and everybody in the Jogo, and also the live streaming team for making this happen. Thank you. Have a great evening. Bye-bye.
Thank you. Bye.